Good evening, everybody, and welcome to this international webinar at Believers Church Medical College and Hospital. This is our 38th webinar, and it's a great privilege and honor to have with us to talk on allergic rhinitis. Dr. Glenys Kathleen Scadding, the Honorary Consultant Physician, Royal National ENT Hospital, London, Honorary Senior Lecturer in Clinical Immunology at the University College London School of Medicine, President of the UK Semiochemistry Network, Euphoria Lead for Rhinitis, Scientific Chief Editor for Rhinology Section, Frontiers in Allergy, Chair of the Trustees of Rhinology and Laryngology Research Fund, past President of the British Society for Allergy and Clinical Immunology, past Chair, European Academy of Allergy and Clinical Immunology Ethics Committee. She is the recipient of BSACI William Franklin Medal for Outstanding Services to UK Clinical Allergy, Allergist of the Year 2011, Allergy UK, Clemens von Perquet Award for Research from the European Academy of Allergy and Immunology, Walter Jobson Horn Award of British Medical Association, World Allergy Organization Outstanding Clinician, Jack Pepys Lecturer BSACI 2020, and much more. Research interests of Dr. Scadding include rhinitis and its comorbidities, including asthma and rhinosinusitis, aspirin hypersensitivity, and sublingual immunotherapy. Author of over 300 peer-reviewed publications. It's a great honor to have Dr. Scadding with us. Ma'am, we welcome you to this webinar, and it's a wonderful feeling to have you in our midst. Welcome, ma'am.
Thank you.
And to moderate our session, we have our Associate Professor of Otorhinolaryngology and Head of Medical Informatics, Dr. George Thomas. After completing his undergraduate medical education from the prestigious Madras Medical College, he went on to train in ENT at the prestigious CMC Vellore. And currently he's doing a great work as ENT surgeon at Believers Church Medical College and Hospital, and is also doing groundbreaking work at the Medical Informatics Department. Sir, it's a great privilege and honor to have you as moderator for this session. Welcome, sir.
Thank you.
Okay, and now to give an introduction to the session and to hand over the session to Dr. Scadding, we have Dr. George. We are handing over the session to Dr. George Thomas. Over to you, sir.
Good evening, everyone. Thank you, Jacob, for your kind words. And once again, I welcome Dr. Glenys Kathleen Scadding, a renowned allergist and immunologist from UK, to spend some time with us and enlighten us about her experience in treating allergic rhinitis as well as prevention of comorbidities and complications related to allergic rhinitis and asthma. Her works related to allergic rhinitis will help us in improving our knowledge as well as our treatment plan in treating our patients with allergic rhinitis. Over to you, ma'am.
Thank you very much, both of you, for that really lovely introduction. It's a great pleasure for me to be speaking to you today, and I thank you very much for the invitation. I'm going to share my screen with you now and show you my talk, which is, as you have said, absolutely about allergic rhinitis. And it is a topic close to my heart because it is something from which I myself suffer. And I suspect that something like 20 to 30% of you in my audience also have allergic rhinitis. I'm going to divide my talk into three parts. One of them, the first one is, what is it? Why does it matter? The second one is making a diagnosis. And the third one is treatment. Now, what is allergic rhinitis? Well, it's actually a symptom complex. And one second, I'm having problems moving my slide on. What is not happening? Let's see. Here we are. Here's the definition. The word rhinitis means nasal inflammation, but it's defined clinically by symptoms. And patients need to have 2 or more of these symptoms: nasal running, blocking, itching, sneezing, for more than an hour a day. In something like 50 to 70%, the eyes will also be involved, as you can see from the picture on the right, with itching and watering and redness. And the rhinitis, when it involves IgE, is called allergic rhinitis. Let's move on and see the next slide. 1 second, that's better. Here we go. This is a cartoon from a paper I wrote in The Lancet a few years ago. It's a very simplified version of what is happening in rhinitis. But what it shows you is that on the nasal epithelium, there are various external influences. Some of them are allergens, some of them are other things: viruses, pollution, cigarette smoke, bacteria. And they are alarmins that alert the immune system. And this combination can result in dendritic cells taking up allergen, looking at fragments of it, presenting them to T cells, which then manufacture cytokines. 2 of these cytokines, IL-4 and 13, tend to make B cells mature into IgE-producing plasma cells, and then mast cells get coated with that IgE, which acts as a receptor for further allergen contact. When that happens, the mast cell degranulates and releases mediators, which have a variety of effects, mainly that running, itching, and sneezing, which I've been telling you about, and later on, the nasal blockage. There's that early phase to the response, and also a later phase, largely driven by IL-5 from the T cells, but also by things like prostaglandin D2, in which blockage, hyperreactivity, and poor sense of smell can occur. So this is the basic reaction. And the first thing to notice is that actually, if we can get rid of the allergen and if we can get rid of all these alarmins, then we might do rather better for our patients. What allergens cause rhinitis? Well, in the UK, we've got a pretty good idea now, and you can see this allergen calendar here. And by taking a history from a patient and when they have symptoms, you can work out really largely what allergen they are likely to be reacting to, although there is, of course, overlap. In other parts of the world, the allergens are different, and they will be different again in India. There's an article, a link here that you can look to see what is happening in India. But mainly they are pollens and also house dust mite. It's a very, very strong allergen for rhinitis and for asthma worldwide. In places like the Middle East, sand exacerbates the rhinitis quite markedly. But what you will note is that nearly all these allergens are breathed in. They are common environmental substances that enter through the respiratory tract. Food allergy very rarely causes rhinitis, although the opposite can occur, as I'll explain in a minute. Now, one of the remarkable things that this gentleman, John Bostock, who was a doctor, when he got allergic rhinitis, when he was in his 20s, he described it to the Royal Society of Medicine in London in 1817. And he described the nasal symptoms, he also described some chest symptoms, and he noticed quite a lot of the comorbidities, including feeling very tired and not very well. But this was a remarkably rare disease then. It took him about 9 years to find 23 other people who had the same disease. These days, it would take you 9 minutes. So what's happened? Because now 26% of the UK population has allergic rhinitis. Why has this rare disease suddenly become much more common? And is that the case all over the world? No, although it's going that way. If you look at the epidemiology, and this is in teenagers, young teenagers in 1997, David Strachan has written this magical paper, you can see that westernized societies, Australia here, the UK, the USA, have much higher levels than places like China, Greece, India, and Indonesia. But how has that changed? Well, looking again, doing exactly the same questionnaire, this is actually the third time versus that first time, you can see that in many countries, in the 7 to 8 year olds, there is an increase in prevalence, and again in the 13 to 14 year olds. And that increase is much greater than the little change or the decreased prevalence. So allergic rhinitis is becoming more common throughout the world, and those non-Westernized societies are catching up as they approach Westernization. So we're doing something badly wrong. And it's not only rhinitis, which is increasing, as you can see from this, atopic eczema is also increasing, and to an extent, so is asthma. Now I asked why, and there is the hygiene hypothesis, which suggests that we need early contact with bacteria and other viruses, perhaps, and other organisms, microorganisms. And we need that in order to train our immune system correctly. And those organisms may be outside us, but they may also be within us in places like our gut and also possibly our respiratory tract. And this is a very big area of research and interest. And during your working lives, I think you will find quite a lot of therapies directed towards altering the microbiome. Okay, so how do patients with allergic rhinitis present? Well, I've told you about the classical symptoms: running, blocking, itching, sneezing. But sometimes patients present with a comorbidity. That may well affect the ears, especially in smaller children when the eustachian tube connecting the nose and ears is shorter and more horizontal. And it may be eustachian tube dysfunction, so they can't equalize the pressure when they go into a tunnel in a train or go up in an aeroplane. It might be actually otitis media with effusion, which starts after a cold and refuses to go away. Rhinitis can also present with symptoms in the lower respiratory tract, such as cough, poorly controlled asthma, prolonged and frequent respiratory tract infections. And one of the other presentations, which is often missed because we forget to ask patients about this, is sleep. Having a blocked up nose makes it very difficult to get to sleep. Just try it tonight. Put a peg on your nose when you lie down. Really, really hard to go to sleep when your nose is badly blocked. And the other thing that happens is you wake up in the middle of the night with a very dry mouth because you've been mouth breathing. And through those effects on sleep, rhinitis reduces people's ability to clear their brains, to sort and file things, so they think less well, they do less well at school and at work. And then, of course, it can present with rhinosinusitis. The inflammation in the lining of the nose can extend to the sinuses. And finally, it can present as something that looks like food allergy, but is not really. And that happens when the sensitization is to a pollen from a plant, but it also is present in a certain food. And one of the very common ones in Northern Europe is birch pollen allergy and apples. About a third of patients who have birch pollen allergy find if they eat an apple, they get itching and tingling in their mouth. It's not primary allergy. It is it's not primary food allergy, it's primary respiratory allergy, but it affects certain foods as well. And for many of these patients, the food problem is what brings them to the doctor to find out what's going on. So there are all sorts of ways in which allergic rhinitis can actually present. One second. There we go. So from what I've been telling you, this is a disease which underlies many complications and comorbidities. It affects sleep, it can precede asthma, and it's a major risk factor for poor asthma control. It affects quality of life and productivity at work and school, and therefore it is actually a very costly disease. It is well worth treating properly. And this slide just shows the impact on quality of life. And the higher the graph, the worse it is. And you can see here that sleep was affected in over 60%. 1,700 people had their sleep affected. And the second one was mood. Rhinitis reduces your joy in life. So it's very, very worth taking absolutely seriously. And how do you convince other people of this? Well, money is the usual way, especially if it's people paying for things. And this is the productivity loss per employee per year. Now, it's rare for allergic rhinitis to stop people actually going to work and school, but that occurs in about 3 to 4% of sufferers. But it's presenteeism which matters. And that's people having rhinitis, having probably slept badly, going to work or going to school and not doing their job or their learning very well. And the cost, the mean productivity loss per employee per year for rhinitis is right over to the right-hand side of this slide. And it's higher than things like diabetes and asthma and hypertension all added together. So this so-called simple disease really, really matters. And that's why it's worthwhile treating it properly. And the other reason I mentioned briefly is that rhinitis can turn into asthma. This is a survey from Europe following up people in their teens and 20s for 8 years and monitoring them for the development of asthma. The patients in black were controls. Those above them, who are in pale purple, have atopy. They have IgE to various allergens, but no rhinitis. The next line up, the greenish ones, are non-allergic rhinitis, and the top line is allergic rhinitis. And you can see that over 8 years, those patients with allergic rhinitis are over 3 times more likely to develop asthma than patients who don't have rhinitis at all. So if you treat rhinitis properly, can you prevent asthma? Possibly. And what about rhinitis and asthma in India? Well, this is a study that I recommend that you read. This looked at over 1,000 asthma patients, and 65.24% had coexisting allergic rhinitis. But where you are in the southern regions of India, it was 80%. Sneezing was the commonest symptom, following by a runny, watery nose. And most of the patients had seasonal disease, probably related to various pollens, including coconut. The coexistence of allergic rhinitis and asthma was associated with a personal and a family history of atopy, smoking, exposure to biomass fuel, and pets and animals at home. So those are the important factors. Now, if you do have rhinitis together with asthma, you find that allergic rhinitis impairs asthma control. And in this big study of about 4,500 patients in the UK, the patients who had significant rhinitis were 4.62 times more likely to have uncontrolled asthma compared to patients with no rhinitis. Even the mild rhinitics were twice as likely to have uncontrolled asthma. And if you look at the effect of smoking, that gives you a 4.33. Significant rhinitis is worse than smoking, and we know that smoking is very bad for asthma. And one other figure I want you to look at on this graph is the low adherers, the people who don't take their medication for asthma very regularly. And they were less likely to have uncontrolled asthma than were the rhinitics. So the nose is very, very important to the chest. And that makes sense, because how do we breathe? We breathe in through the nose. So it's worthwhile making the nose work properly. And there's good evidence that treatment of rhinitis can reduce emergency visits and hospitalization for asthma. So in this first part of my talk, the take-home messages is that allergic rhinitis is now a highly prevalent immunological disorder involving IgE-mediated initiation of an inflammatory cascade in the lining of the nose. The main symptoms are running, blocking, itching, and sneezing, and they can be seasonal or perennial or both. Multimorbidities include the local structures, eyes, throat, ears, chest. Quality of life can be impaired, particularly when sleep is disturbed. And allergic rhinitis can precede and predispose to asthma. It worsens asthma control, and its treatment improves asthma outcomes. And it is a costly disease because of presenteeism at work and at school. Okay, that was part one. Let's move on to part two. How do you manage allergic rhinitis? Well, it's like managing almost any other disease. First of all, you ask the patient to talk to you about it, to take a history. And then you examine the nose, and then you look to see if you can establish what the allergy is that is driving it. And you may need to do some other tests just in case you find it is not allergic rhinitis, or you want to rule out other disorders, because there are multiple causes of rhinitis. And this is from that same 2011 paper. And you can see from this that rhinitis can be allergic or non-allergic. It can also be occupational, and that can be both allergic and can be non-allergic. The non-allergic can be infective or non-infective. And then the non-infective has a range of disorders, and there are a little raft of other disorders at the top, including neurogenic, gustatory, emotional. So there are a lot of causes of nasal inflammation and symptoms, but allergic rhinitis is common. And if you're unsure what the cause is, and the patient doesn't have any danger signs like pain, like frank bleeding from the nose, like unilateral disease, then it's worthwhile trying a trial of rhinitis treatment. Now, I'm going to be using the Euphoria Pocket Guide to talk to you today. And this Euphoria is a European charity dedicated to trying to improve the care of patients with airway diseases. And I'm hoping that this will be up on the Euphoria website soon. They're just redoing the website. And here, one of the useful things, I think, is symptoms suggested for allergic rhinitis when related to allergen exposure. And they're the ones I've been telling you about. And then there are symptoms less suggestive of allergic rhinitis, unilateral symptoms, nasal obstruction without other symptoms, discolored secretions, pain, recurrent epistaxis, anosmia, lack of smell, a thick posterior discharge, or isolated rhinorrhea. And if your patient has one of those, ask your friendly ENT surgeon to take a good look at them. The other thing on this slide that I'd like to show you is something very simple called a visual analog scale, which I guess you've used in many conditions. This is a 10-centimeter line, and you ask your patient how bothersome the symptoms are. And if the symptoms are not at all bothersome, they should make a cut towards the 0 end. If they're very bothersome, towards the 10 end. And wherever they make the line, it helps you to know how well their disease is being controlled. And 5 and over means uncontrolled rhinitis. And that's useful in deciding about therapy. So what should the physician do? Well, we've talked about the history, and then you want to know the severity using that visual analog scale, and also ask what symptom bothers your patient most, because you want to direct your efforts at getting rid of that symptom. And then you and the patient are working together, and that's concordance, and that's very important in this disease and in any chronic disorder. Then you want to examine the nose. How do you do that? Well, it's quite simple. Sorry, that's the visual analog. How do you examine the nose? In children, often you can see that there is obstruction because they have their mouths open to breathe. You don't always know if that's rhinitis or if it's the adenoids, but you can use an otoscope to look very gently into the nose and see if they've got very big, pale, swollen inferior turbinates. And interestingly, don't do a lateral X-ray. They're not very good at diagnosing adenoid hypertrophy. You're giving the child radiation, which they don't need. Much better to give them a trial of rhinitis therapy, because that can actually improve the adenoids, especially if you use intranasal corticosteroids, which are safe in small children. In older patients, you can use anterior rhinoscopy with a head mirror and just opening up the nose, and you can see here the very nice picture. Here's the pale, boggy inferior turbinate, and you can just see the middle turbinate up above, and that's the septum on the left-hand side. Or you can use one of these very nice Hopkins rods. Hopkins was a Welshman who invented this wonderful laser light to look in the nose and relay the picture to a screen on which you can see what's going on. And if you turn the patient around the other way, the patient can also have a look at what's going on in their nose. How do you know what you're looking at? Well, the inferior turbinate is usually pinkish, sensitive, and you can't get behind it. It's attached laterally. Nasal polyps hanging down into the nose are more whitish grey. They are insensitive and not attached laterally. So if you take a little gentle probe and just push whatever's hanging in those very gently, if the patient leaps backwards, it's a turbinate. If they don't take any notice, it's probably a polyp. If you're not sure, ask your ENT surgeon. Right, so we've had a look at the patient. We've said, yes, they've got rhinitis, they've got the swollen inferior turbinates, they've got predominantly clear secretions. What's causing it? Well, from the history, you've probably got an idea of what the patient is exposed to and when they get symptoms. You do allergy tests to find out whether the patient is actually sensitized to that allergen. Now, we in the UK have a basic set for rhinitis, and that always includes a negative control, which is saline, and a positive control, which is histamine, to which the patient should develop a wheal. And then the other 4 that we use to pick up over 90% of patients: house dust mite, grass pollen, cat, and dog. But in India, this will be different. You can see the result of one test here. And what I'd like you to notice is that there are no wheals at all. The test is read at 15 minutes. The allergen is pricked just under the surface of the epithelium. Nothing's happened at all. Is that a negative test? No. It's actually a failed test because the patient has not reacted to the histamine. And it may be that they're taking antihistamines, and that's why it's failed, in which case you would send off a blood test. Or it may be that they have been using a lot of corticosteroid on their arm, because that can reduce the tests. Oral corticosteroids generally don't unless they're taking about 30 milligrams a day. Here's what a positive test looks like. And they've got a nice positive to the histamine, but they've also got multiple other positives, nice wheels greater than 3 millimeters in diameter. And this one's very active. It's even got a pseudopodium there. And then you go and look and see whether what you've tested the patient to fits with the history. You always relate the skin prick test to the patient's history because false positives occur and false negatives occur. If you hadn't got a positive on this, you might want to think again about what the patient is exposed to. Healthcare workers, latex, animal contact, test the relevant animal, bakers, wheat and amylase, damp housing molds, late summer in the UK, we have a lot of molds. And the one exception about foods is small children. Very occasionally, they will get rhinitis with foods, never as isolated rhinitis. They will always have other allergic diseases, usually gastrointestinal, possibly eczema, possibly asthma. But that's the exception. For most patients, rhinitis is not caused, allergic rhinitis is not caused by food allergy. And then what are the blood tests? Well, there's the radioallergosorbent test, the classical immunocap, which can be done on 40 microliters. It can look for one allergen or a mixture of allergens. And more recently, we have the more expensive test, which looks for multiple allergens, specific IgE directed against allergen components, because each allergen is actually made up of several different allergenic molecules. And this is the major beech allergen, BET-V1 here. This is the hazelnut allergen, core A1. And this is the apple allergen, MALD1. And you can do that. It's much more expensive, and for most of your rhinitis patients, you really don't need it. Now in India, your subcontinent has a very large area, a huge population, and is very diverse in climate and flora and in food habits. So you will need to know the allergens in the part of India in which you're working. As I said earlier, the major sources are pollen, house dust mites, fungal spores, insects, and I just take this back. Some food allergens, if you inhale them, can cause rhinitis. I should have mentioned that, because especially when you're cooking things that are highly spicy or fish, the steam can cause allergy because it's inhaled. And here are your major pollen allergens, and you can see. Sorry? You can see it even includes the coconut and eucalyptus. What else should you do before you finish seeing the patient? I mentioned rhinitis and asthma. You should check for lower airway symptoms. Ask them about wheezing, coughing, what happens after exercise. Do they have a lot of colds, laryngitis, bronchitis? Does their chest feel tight, or do they have problems breathing out? And do an objective airways measurement, peak flow, spirometry, and get them to fill in the asthma control test if they have asthma. You may well pick up asthma that the patient didn't know they had, and you may make their lives very much better by treating it. So the take-home message of this part of the talk is that the diagnosis rests on an accurate history of the nature and severity of symptoms and their timing. You should ask about the multimorbidities, including asthma, and examine the patient, examine the nose, but also, if you can, examine the chest, look at the skin, look in the ears, and check on the sinuses if you have an endoscope. and usually tests for the relevant specific IgE, skin prick or blood tests. Always interpret those in the light of the history. Now, there is a phenomenon called local allergic rhinitis. And that means that the patient has IgE in the nose, but not in the systemic circulation. And that appears to occur more in certain countries than others. It appears quite common in southern Spain. And the only way to diagnose that is with a nasal allergen challenge or looking at the nasal secretions. If all the tests you do, allergy tests, are negative and that challenge is negative, the patient has non-allergic rhinitis, and you need to look at all those other possible diagnoses. But one other thing to mention is that mixed forms of rhinitis occur. Your patient with allergic rhinitis may also have some neurogenic component to their rhinitis, and that can complicate the issue. So let's move on. Section 3, treatment. This is to teach you the various treatment modalities, their effectiveness, and the possible adverse effects. And again, this is the Euphoria pocket guide. It gets you to diagnose allergic rhinitis, to classify the patient according to their major symptom and the response to any treatment they might have taken, and then to define the therapy that you're going to use, the treatment, how you're going to educate the patient and make a partnership with them. And this is really important because patients won't take the medicine unless they understand why they're supposed to take it and how much good it's going to do them and when they're supposed to take it. You select the product, you activate the treatment plan, and then you follow up the patient. And if they're controlled, that's fine. If they're uncontrolled, you need to go back, check you've got the diagnosis right, check you've got the right kind of therapy, and fine-tune your plan. This is the Euphoria allergic rhinitis algorithm. And again, I hope you can find this on the Euphoria website. And you remember that most of the things causing rhinitis land on the nasal mucosa. So everybody should be using things like avoidance measures for allergen and pollution as much as they can. And a very simple thing to do is to wash the nose out with saline. And I advise all my patients to do this, either by making up the saline themselves with some previously boiled water and a pinch of salt in a mug of water, and sniffing it up their nose, or by buying a spray or a spray bottle. Many patients will start off with self-management. I don't know what's available in your pharmacies, but in the UK, you can buy nasal corticosteroid or antihistamine, intranasal or oral over the counter. Or patients may be diagnosed because they failed to respond to that or because they've gone straight for medical help. If patients are uncontrolled, that's a visual analog score of less than 5, then we'll go on to more detailed therapy. Just to show you the evidence for saline. Sorry, we've got a raised hand. Did you want to say something?
Don't worry about it, ma'am. Don't worry about it.
Okay, fine. Don't worry. I thought that the internet might have failed. Okay, this is a Cochrane review in which I was involved, and this shows you that saline is favored over no saline. Saline is clearly better than no saline. And saline is less likely to cause side effects than intranasal corticosteroids. So this is a very safe, easy method of treatment, available to everyone, cheap, and suitable from the oldest to the youngest, and even for pregnant women. So I would advise you strongly to advise saline for all your nasal patients. Then what about these antihistamines that the patients might be taking? It says here non-sedating. Why does it say that? Well, oral antihistamines work very well against running, itching, and sneezing. They help a bit with eye symptoms. they don't have a lot of effect on nasal blockage. But the first generation of antihistamines are sedating. They cross the blood-brain barrier and they make people sleepy and they make it difficult for them to think straight. And this exacerbates those symptoms that I told you are also caused by allergic rhinitis. And you can see this in this study here. This was children doing a computer game, and the longer they could keep that game going, they had to keep a farm in a desert. The longer they could keep their animals alive, the higher their score. And these are children without allergic rhinitis. And in blue, you can see the children with allergic rhinitis treated with placebo. And you can see the effect on learning that allergic rhinitis has. Now look at the right-hand score, the red one. That's children with allergic rhinitis treated with diphenhydramine, a first-generation oral antihistamine. Their performance is worse still. So the sedating antihistamines exacerbate the psychomotor retardation of allergic rhinitis and should never be used. The yellow one is loratadine, a non-sedating antihistamine. And if you want to know which ones are which, the ones at the bottom of this table, the last four, are all that old-fashioned first-generation antihistamine. Avoid them like the plague. Choose one from the upper area here to use, so you're not giving your patient an additional burden by treating them with a sedating antihistamine. What are the most effective treatments for allergic rhinitis? Are antihistamines the most effective? No. They're very commonly used because they're easy to obtain and they're tablets, but actually the number needed to treat, that's the number of patients to which you need to give the medication to make one person better, is 15.2. That's quite high, isn't it? The most effective medications in this study here, which was a while ago, I think we've got even more effective ones now, but in this study, the most effective medications were nasal sprays, and that's nasal corticosteroid sprays, with a number needed to treat of 4.4, and immunotherapy with a number needed to treat of 4.6. One other thing to notice from this table is that the nasal antihistamines are much more effective than the oral for rhinitis symptoms. So by putting the antihistamine straight onto the nasal mucosa, it works much better. And these days, the most effective medication we have is a combination of nasal corticosteroid and nasal antihistamine. But let's move on and look at those intranasal corticosteroids a minute. There are meta-analyses showing that they are better than oral antihistamines, topical antihistamines, that's intranasal, leukotriene receptor antagonists, and they're also better than the combination of an antihistamine and a leukotriene receptor antagonist. So these are probably the most effective single medication for allergic rhinitis. But there's one thing that you really have to do every time you provide an intranasal corticosteroid for your patient. And that is you need to teach them how to use it. And I'm going to show you that now. Tell them to put their corticosteroid spray next to their toothbrush. And in the morning, just before they clean their teeth, to pick it up, give it a shake, take off the top, and then to cross their arms. Because you want to use the right hand to treat the left side of the nose. And you put one spray up, one spray back on that lateral wall. If it's a child, it's probably just one spray. Same the other side, change hands, one puff up, one puff back. Wipe it, put it away, clean your teeth. Cleaning your teeth takes the attention away from the nose, and that will help to stop sniffing. Because you want to leave the solution in the nose for as long as you can. It won't stand still. Mucociliary action will move it backwards all the way over the nasal mucosa and right down to the back of the throat. That's what happens to everything that goes in your nose. But that is when that spray works on the nasal epithelium, which is where these reactions are starting and taking place. Once it's at the back of the throat, it doesn't matter what you do. You can swallow it, you can spit it out. It's done its job. But if you don't teach patients to do that and to allow the spray to work, they will do this. They will put it straight on the septum. They will press the nose so the spray goes hard onto the septum. They will sniff it all back. They'll damage the septum. They'll make it irritable. They'll sniff all the spray straight back to the back of the throat, and they won't work. And simply by teaching them what to do, you can make their lives very much better. Now, I have a secret weapon about this, and I'll show you that in a minute or two. But that's one of the major things I want to for you to take away from this talk. You need to know about the steroid that you're giving, because your patient will possibly worry about the word steroid. And the least absorbed nasal steroids. Sorry, could you mute, please? Could whoever is making the noise, please mute? You need to understand which steroid you're using, because what happens to the steroid is that it goes into the nose and there is a little local absorption, but most of it goes down to the stomach, and the absorption there and the hepatic metabolism varies greatly between molecules. So what the molecules you want to be using are one of these three on the left, which have minimal systemic bioavailability. And I will use these in children quite happily: fluticasone furoate, mometasone furoate, fluticasone propionate. The others have variable absorption, and the very heavily absorbed are betamethasone drops, betnosol, and that is only suitable for very short-term use in adults, and we use that for a medical polypectomy combined with oral corticosteroids. So do be able to reassure your patient that what you are giving them is safe, and what you're giving their child is safe. And this is some nice data on growth in children over a year. And if you have a steroid effect, a deleterious one, growth decreases. What you see with this is that the mometasone, which is in gray, actually improved growth at 2 time points, probably because it improved allergic rhinitis, which improved sleep, which improved growth hormone secretion, because that happens during sleep. And I've got similar data on this for fluticasone propionate. So you can give those molecules to children without a worry. And I will even use them in pregnant women, because one will continue inhaled corticosteroids for asthma in pregnant women, and they are far more absorbed because of the great surface area of the lungs than our nasal steroids. Okay. So maybe your patient's taken a nasal corticosteroid and antihistamine, but they're still uncontrolled. So they've come to see you, you diagnose allergic rhinitis. And what do you give them? Well, if they've had an antihistamine, I would give them a nasal corticosteroid. But if they had a nasal corticosteroid, there is no point in adding an oral antihistamine to a nasal corticosteroid. It doesn't make any difference. What you need to do is add an intranasal antihistamine. And you can do that now in a combination spray, which has got both in it. And I am finding this extremely useful. It's got azolastine and fluticasone propionate in it, and its trade name is Dimista. I don't know if you've got it in India, but I think you'll find it very useful when you do get it. And this shows you the reduction in overall nasal symptoms. The reduction is shown going positive. So Dymista is significantly better than steroid alone. It's significantly better than azolastine alone. And its onset of action is significantly faster than both of them. So it is a very useful molecule also because it treats not only the nasal symptoms, but also the eye symptoms. And let me just show you this. Here are the nasal symptoms, and you can see the Dymista is better than FP or azolastine. And here are the eye symptoms, and again, the Dymista outperforms both fluticasone propionate and azolastine. And what's also very interesting, the data I've shown you in those last two slides is trial data from clinical trials. So that shows the efficacy of a medicine. But actually, in the real world, things are very different because real world people don't get into clinical trials much. Old people are excluded, young people are excluded, pregnant women are excluded, smokers are excluded, people taking other medications are excluded. So usually, a drug in the real world performs less well than in clinical trials. But interestingly, Dymista in this real world study in 2,500 patients actually performed better than it did in the clinical trial. So this is a very good drug for patients who have not responded to other therapies. Sorry, I'm having a little problem with the slide advancing. There we are. It also works extremely quickly. This is a chamber study. This is putting patients into a room altogether, and they have different treatments, and then you expose them to the allergen, and you see how well those treatments are working. They don't know what they've had, you don't know what they've had, and so you get a very nice outcome. And the Dymista here is shown reducing symptoms very rapidly. And this is the first time that any drug has been shown to have an onset of action of 5 minutes. And the first time its efficacy has been shown to exceed that of the fluticasone propionate plus loratadine, which did nothing significant until about 150 minutes. So we've now got your patient again. They've had that combination therapy and they are still uncontrolled. What do you do now? Well, Euphoria suggests several things. One of them is the possibility of add-on therapies, and these are shown above. If they've got isolated watery rhinorrhea, one might want to give them ipratropium. If they've got a very blocked nose, you might want to use a nasal steroid briefly. If they've got ocular symptoms, you might want to use an antihistamine, possibly eye drops or chromone eye drops. And if they've got bad blockage, you could use a decongestant just briefly. Or if it's very inflammatory, brief use of an oral corticosteroid. You might want to consider asking your friendly ENT surgeon to take another look, because if your patient has a very deviated septum or huge inferior turbinates, then the sprays that you're giving them may not be getting into the nose properly, and they might need an operation to enable medical therapy. And also at this stage, you might want to think about allergen-specific immunotherapy. And I'll come back to that in a minute. But what is really important is this item on the right here, patient participation in treatment plan. And one of the things that's vital is educating your patients about the nature of what they've got, the fact they might need to treat it long term. I've treated my allergic rhinitis for well over 20 years with intranasal corticosteroid. Teach them how to use it, tell them about the side effects, give them contact number or email, and you can tell them to monitor their disease these days on a mobile. Now, I mentioned my secret weapon earlier, and here she is. She's my nurse. And she can talk to the patients When I've had a chat to them and find out what's wrong, I will send them out with a treatment plan to Yvonne, and she will go through it with them. She'll show them the medicine, she'll teach them how to take it, she'll tell them what to expect, how to get in touch with her if they have problems. And it is hugely rewarding. She'll show them the diagram about the safety and about how to use a steroid. And these days, she can explain how they can use a mobile phone to monitor their symptoms using that visual analog scale. And that can help them to keep better control of their disease. This is really, really vital. Getting on the same side as your patient will make a big difference. Now, of course, that photo I showed you of Yvonne was taken before the days of COVID. Very difficult to get up close and personal now. What should we be doing? Well, we should still be giving patients inhaled and intranasal corticosteroids. These are not immunosuppressive. Nasal steroids actually improve innate immunity in the nose. They improve mucociliary clearance. And they also reduce the receptor to which the COVID virus binds. It's important that people with allergic rhinitis wear masks, because if they sneeze and they happen to have COVID, possibly asymptomatically, as happens in 1/3, then they will be spreading the virus everywhere. So masks are vital for them. Patients who are symptomatic or have had exposure or positive PCR should not be coming up to your hospital to have their allergen immunotherapy. We would want to switch them from subcutaneous injection immunotherapy to sublingual. And there's a paper in the Wild Journal which you might like to look at with all that on it. So patient education is vital to achieve concordance with any treatment in any disease, but particularly so in a long-term disease where you've got to do something every day. All AR sufferers should aim to avoid allergens and irritants. Mild disease might well be controlled by antihistamines, but they must be non-sedating. Regular use is more effective than intermittent. That's true for antihistamines, it's true for corticosteroids. More severe sufferers should receive intranasal corticosteroids, which are non-systemically bioavailable. They should be taught how to use them, and again, that regular use is better. If they're uncontrolled on this regime, then they should have the combination therapy of intranasal steroid plus intranasal antihistamine. And if you don't have that single combined spray, you can use the 2 sprays separately, but it's harder for your patient to do that. Failure at this stage requires specialist referral for consideration of other therapies, including allergen-specific immunotherapy. And again, this is the Euphoria guideline, which tells you all about allergen-specific immunotherapy, which is also called desensitization or allergy vaccination. It can be done by 2 different routes, by injection, subcutaneous called SCIT, or under the tongue tablets or drops, known as SLIT, sublingual immunotherapy. It's the only treatment with a disease-modifying capacity. It does reduce symptoms more effectively than most of the pharmacotherapies, and it enhances quality of life. It induces immunological tolerance. It persuades the immune system to think of the allergen as something harmless, not as something to be reacted against. And it does have the potential to prevent that switch from allergic rhinitis into asthma. And that's been shown not absolutely conclusively, because it wasn't a double-blind placebo-controlled study, but it was a 10-year study, and children given grass pollen immunotherapy for hay fever were 2.5 times less likely to get asthma by 3 years, 5 years, and 10 years. So the effect seems to persist. So perhaps we should be thinking more about using allergen-specific immunotherapy to switch off allergies early on in life. And there's more details of this on the website. What about India? Well, until you know which allergens are really responsible and you can get good extracts, it's hard to get good allergen-specific immunotherapy, but there are papers, and this is a nice one about placebo-controlled immunotherapy with Cocos nicifera. And there's another paper about subcutaneous immunotherapy, a retrospective study on the safety of immunotherapy in pregnancy. One would not start immunotherapy in pregnancy, but you can continue it if it's ongoing. So it is happening in India, and I'm hoping in the future it will be happening more. So here is the Euphoria algorithm for you to learn and use in your practice. A summary of this whole talk is that allergic rhinitis can often be diagnosed on the history, but look for atypical presentations: sleep problems, eye problems, sinus problems, ear problems, asthma. It can have a major impact on quality of life and educational attainment. Try avoidance strategies, but if possible, identify the allergen which is driving disease. And it's often just one or two allergens. Even in patients with multiple positive skin prick tests, often just one or two of them are really the things that the patient is in contact with that's driving disease. I've told you about the medications listed here and how to use them. Allergen-specific immunotherapy may be indicated for resistant rhinitis. And treating rhinitis may improve asthma control, and it may be possible to prevent asthma by treating allergic rhinitis with allergen-specific immunotherapy. Thank you very much for listening to me. I hope you found some of this useful, and you'll be able to practice it with your patients.
Thank you very much, ma'am. That was very informative. In fact, listening to your lecture, everybody would have become an expert in treating allergic rhinitis. Thank you very much. However, we have a couple of questions which have come up. Can I share the questions with you?
Sure.
Okay. One of the questions which came up was allergic rhinitis. Do you find other autoimmune diseases more common with patients with allergic rhinitis, especially thyroid diseases?
Not really, no. I did look at this once in my practice, and the answer was no. I didn't find it more common.
Then usually in our practice, we encounter very high incidence of rhinitis medicamentosa with people with allergic rhinitis. Yeah. So how to go about with people with two conditions like this?
That's a very good question. We don't see a lot of rhinitis medicamentosa, which occurs when people overuse nasal decongestants. The first thing to do is to explain to the patient what is happening. And what I usually then say to them is that you have to withdraw the decongestant from one nostril from now on. You are never going to use it in that nostril again. You are allowed for the next week to use it in the other nostril only when you are desperate, and that will often be in the night, maybe to go to sleep, or maybe in the middle of the night. And I explained that when you lie on a pillow, there's a thing called the nasal reflex. So when you put your head down, this side of the nose closes and this side opens up. So you want to have the side that you're treating not on the pillow, so that you can breathe at night. And while we're doing that, I usually give them a brief course of oral corticosteroids, 0.5 milligram per kilogram for about 5 days, together with a nasal steroid. Now, I would have used in the old days probably betnosol for this, but these days I would probably use Dymista, that combination spray. And you keep in touch with them, because they're going to need support. These patients are both physically and psychologically addicted to their decongestant. So keep in touch. This is what I'd ask my nurse to do, to find out after those 5 days how they're getting on, to get them through the next week. And then you get them back, you have a look at them again, you encourage them, and you can wean them just onto the Dymista. And that will quite often work. Once they've realized that they've made their own lives worse by their dependence on that decongestant. And then you get on with working out what's made the nose blocked in the first place.
Another question from our pediatrician was, what would be the youngest age at which saline wash can be advised? And also, is there any advantage adding sodium bicarbonate into the solution?
Yeah, good question. I think you can even wash the nose out in babies. The French are doing this all the time. They have a Rhinomère bébé that they use very gently in babies for cleaning the nose. Yes, we do tend, when we're advising patients, if they can, to put a little pinch of sodium bicarb with the salt, because the alkalinity helps to break up the DNA and things in the secretions and make them more easy to move. That's true. In fact, seawater, sterile seawater, is probably superior to almost anything else for washing out the nose.
Okay. So our next query was, what would be the average duration for a successful slit therapy? And here down in India, patients usually ask, what is your guarantee? Is it 100%? If you do a...
Nothing in life is 100% guaranteed. I think that the slit is, when I was asked to do 20 patients by my hospital to show if it worked, and we had a 75% response rate in those 20 patients. So I think it's probably around there for slit. How long do you do it for? Generally speaking, you need to do 3 years of allergen-specific immunotherapy, either continuously, which is what you would do for house dust mite, or for pollens. We also do a pre- and co-seasonal treatment. For example, for grass pollen, we would start in January and we go on, which is a few months before it starts. We go through the season and stop at the end of the season and then start again the next January. And that means we have 3 7-month periods, which cuts the costs a bit.
Okay. Here we are actually aiming at reducing the hospital and morbidity of the patient, isn't it?
Yeah, yeah.
And you were mentioning about early exposure of antigens to the humans. So how early do you suggest? And playing in the mud, are you encouraging?
Yes, I think we do need to let babies get dirty and play in the mud. We've been keeping them too clean for far too long. If they are immunocompetent, I think they should have exciting, dirty lives. Having contact with animals early on, as we've seen from the farm studies in places like Austria and Germany and the Hittites and the Amish, early contact with animals, early drinking unpasteurized milk, all these things seem to reduce the prevalence of atopy and allergic diseases.
It's been very informative, and there are a lot of take-home points for everyone, including practicing ENT surgeons. Thank you so much, and over to you, Jacob.
Thank you, ma'am. That was just amazing. It was a terrific session. Thank you so much. And I only wish we had 500s and thousands attending this session. It's it's such a pity that we have very less numbers. We have only close to 45, 50. But I really, really wish today, especially, that we had a very good number and we had a national audience. It would have really made justice to your talk. It was such an amazing talk, ma'am, and the way you explained, everybody could understand. I'm a pharmacologist, I could understand, and I bet all our medical students attending this session also could understand. Few of our students have promised to watch this session in YouTube, since they don't have time right now. They are attending some clerkship programs and others simultaneously, so they were not able to come and log in. And yes, ma'am, extremely grateful for that. You've taken time and you've come over live online and you've shared this amazing session with us. We are extremely grateful for that, and we would love to have more sessions from you, ma'am. As as Dr. George Thomas would also agree, we would really love to have more such amazing sessions. And I think as teachers, as practitioners, I think we need to learn the art of teaching and the art of imparting sessions like these from stalwarts like you. Thank you so much, ma'am.
Thank you.
Really, really grateful for that. And would you like to say something, ma'am, as closure?
I would just like to say thank you very much for the invitation. It's been a real pleasure to talk to you, and I hope to meet you again online sometime soon.
Thank you, ma'am. If you visit India, we would love to host you here in our institution.
Okay.
You should visit. And thank you, George.
I'd love to, but it seems unlikely.
Okay, all
Pleasure.
right. No problem, ma'am. And thank you, George, sir, for coming over and moderating this session for us.
Thank you.
You really did an amazing job. Thank you so much. And special thanks to all the students who have taken their time off to attend, and all the other doctors and other participants from elsewhere across the state and the country who have come in and logged in to attend. And I hope that this becomes a culture, internationalization becomes a culture. We listening to stalwarts from across the globe is a great boon that has been opened up, especially after this pandemic. One of the positives of this pandemic, I would take it. And thank you, ma'am, and thank you, sir. And until we come back with another session, yes, it is on the 9th of this month, the coming Saturday, we have one Mr. Doug Reynolds, who is the founder and CEO of Low Carb USA, who is an advocate for weight loss and metabolic transformation, who is coming live with us at 6:30 p.m. on the 9th. So until then, stay safe, wear your masks, keep your social distancing, and keep fighting Corona. Stay positive. And signing off from Believers Church Medical College Hospital. Thank you. Have a blessed evening. Thank you all.